Welcome to the presentation, Incomplete Revascularization, What the Surgeon Needs to Know, a part of the keynote lecture series. For a more detailed discussion, please refer to the accompanying text. These are the subjects we will go over today. For many years, the concept of complete revascularization was considered an absolute truth in coronary surgery. This was based on early publications showing a survival benefit for patients receiving complete revascularization, such as this publication from Emory University from 1981. However, many advances in the field of coronary revascularization have been made in the years that passed since those publications, including changes in the patients referred to surgery, surgical technique and postoperative care, and more frequent use of percutaneous coronary interventions, PCIs, in patients with multivessel disease, along with the option of hybrid coronary revascularization. The current EACTS guidelines on myocardial revascularization state that complete revascularization is recommended as a Class 1 indication, whereas the American Heart Association guidelines do not give any direct recommendations regarding complete revascularizations. Multiple publications have addressed the issue of incomplete revascularization in the past decades. Some have reinforced the notion that complete revascularization is an important goal in coronary artery bypass grafting, whereas others have questioned this truth. Most of these publications are from registries or post hoc analyses, but it is unlikely that a randomized trial of complete versus incomplete revascularization will ever be held. This review will attempt to answer one of the questions that has been part of coronary surgery from its early days. Is complete revascularization the only option in coronary surgery? Or is there room for reasonable incomplete revascularization as part of a tailored therapy approach in a world of sicker patients and multiple treatment strategies? One of the major obstacles to reaching a uniform conclusion regarding the importance of complete revascularization is the lack of a uniform definition of complete revascularization. In general, complete revascularization can be defined by either an anatomical definition or a functional definition. The anatomic classification can be a broad one, implying that all stenotic vessels should be revascularized, regardless of size or territory supplied. A more common anatomic definition is that all vessels with a stenosis above 50% and a size above 1.5 millimeters are revascularized. A functional definition, on the other hand, refers to revascularization only of coronary arteries that supply viable myocardium. Revascularization can therefore be functionally complete, but not anatomically complete. Most trials regarding complete revascularization in coronary surgery use the anatomic classification, since viability data was not available. Moreover, the definition relies on the operative report, since postoperative angiography is rarely used. This is in contrary to similar trials in PCI, where a completion angiography can be examined to determine the completeness of revascularization. We will first discuss incomplete revascularization in on-pump coronary artery bypass grafting. The first trial to systematically address completeness of revascularization was the Coronary Artery Surgery Study, the CAS. The study analyzed the outcomes of more than 3,000 patients with three-vessel disease who underwent isolated first-time CABG between 1974 and 79 with a mean follow-up of almost 5 years. The completeness of revascularization was defined by the number of the three major arteries that received bypass anastomosis. Only 16% of patients in the trial received an internal thoracic artery graft, and the average number of bypasses was 3.2. Patients with more complete revascularization, 3 or more vessel bypass versus 1 or 2 vessel bypass, had improved survival and event-free survival, which was defined as mortality and combined cardiac events of death, myocardial infarction, reoperation, or definite angina, and were more likely to have less severe angina or be asymptomatic. Patients with ejection fractions below 35%, according to a subset analysis, who had 3 or more vessel bypass, had improved survival compared to those who had 2 vessel bypass. In a single-center retrospective analysis of 1,000 patients who underwent first-time CABG with a mean follow-up of 3.3 years, the authors chose what they defined as a functional classification of incomplete revascularization, with complete revascularization defined as the placement of at least one bypass graft distal to a 50% narrowing in each disease territory, and not to every diseased segment. The cohort had a mean age of 68 years and included mostly on-pump CABG, a bit more than 80% of the cases, with a relatively high percentage of double mammary and radial artery used as conduits. The most common reasons recorded for incomplete surgical revascularization were that the arteries were too small, that they were severely diseased, or both. In this study, incomplete revascularization was associated with a 5-year unadjusted increased overall mortality rate and cardiac mortality rate. After adjustment for predictors of death, incomplete revascularization remained an independent risk factor for death with a hazard ratio of 1.85. Of note, the percentage of patients receiving incomplete revascularization was larger in the off-pump group than in the on-pump group. The graphs show the unadjusted survival curves for all-cause and cardiac death in the complete and incomplete revascularization groups. The Cite trial patients were also used to assess whether incomplete revascularization by PCI or CABG influences long-term outcomes. Incomplete revascularization was defined to have occurred when a preoperatively identified vessel, as agreed upon by a surgeon and an interventional cardiologist, with a lesion was not revascularized. Incomplete revascularization was found in 36.8% of CABG patients. The first publication among CABG patients reported the 3-year outcomes. There was no difference in major adverse cardiac and cerebrovascular events at 3 years that was seen between the incomplete and the complete revascularization groups. Independent predictors of incomplete revascularization by CABG were unstable angina, diffuse disease, or a narrowed, below 2 mm segment distal to the lesion, and the number of diseased vessels. Later, a post hoc analysis of the 4-year results of the same trial were published. Of note, this analysis included both the randomized patients and the nested registries. Here, complete revascularization was achieved in 66.9% of all CABG patients. Within the PCI and CABG arms, incomplete revascularization compared to complete revascularization was associated with significantly higher frequencies of 4-year mortality, all-cause revascularization, stent thrombosis in the PCI arm, and major adverse cardiac and cerebrovascular events. The authors commented on the discrepancy between these results and those of the aforementioned trial, and concluded that it is probably reflective of the fact that the nested CABG registry contains more anatomically complex patients compared to the randomized CABG cohort, as evidenced by higher syntax scores in the nested group. The graph shown depicts the 4-year clinical outcomes in the all-comers CABG group. A meta-analysis of studies comparing complete to incomplete revascularization included 35 studies spanning from 1970 to 2012 with almost 90,000 patients. Of the studies included, 28 were observational studies, 5 were group analysis of randomized control trials, 1 was a subgroup analysis of a non-randomized control trial, and 1 was a single-center randomized control trial comparing incomplete and complete revascularization. The authors concluded that complete revascularization was more often achieved with CABG than with PCI and is associated with a 30% reduction in long-term mortality, a 22% reduction in myocardial infarction, and a 26% reduction in repeat coronary revascularization procedure. The lower mortality associated with complete revascularization was seen in both PCI and CABG-treated patients and was independent of the study design and definition of complete revascularization. This is arguably the most statistically powerful and rigorous assessment in the peer-reviewed literature of the impact of complete and incomplete revascularization among CABG patients with multivessel coronary artery disease. The graph is a pooled analysis with relative risk and 95% confidence interval for the occurrence of total mortality in CABG studies. Boxes are the relative risk estimates from each study. The horizontal bars are 95% confidence intervals. The size of the box is proportional to the weight of the study in the pooled analysis. In the early years of off-pump CABG, there was concern whether it carried an inherent risk of incomplete revascularization. Later publications have refuted that claim and proven that, in experienced hands, off-pump CABG results in a degree of revascularization that is comparable to conventional CABG. Several publications have addressed the subject of incomplete revascularization, specifically in OPCAB. A large, single-center, retrospective review comparing on-pump CABG and off-pump CABG is one of the publications with the largest number of patients. More than 12,000 patients that had CABG were in the cohort over a period of 10 years ending in 2006. Patients were divided into 4 groups, 1 to 3 grafts operated on pump versus off pump, and 4 to 7 grafts operated on pump versus off pump. Completeness of revascularization was assessed according to the Index of Completeness of Revascularization, which was defined as the number of distal grafts constructed divided by the number of diseased vessels reported on the preoperative coronary arteriogram, meaning a number smaller than 1 would imply incomplete revascularization. The index of completeness of revascularization was significantly lower among patients with 1 to 3 grafts than among patients with 4 to 7 grafts, and was also significantly lower for patients treated with off-pump CABG than for those treated with on-pump CABG. Proportional hazards regression analysis showed no significant influence on surgery type or number of grafts on long-term, up to 10 years survival within the 4 groups. However, a higher index of completeness of revascularization was associated with improved long-term survival in all groups. The figure is the life table survival curves by number of grafts, 1 to 3 grafts, or 4 to 7 grafts, and surgery type. On versus off-pump CABG. Hybrid coronary revascularization, meaning the combination of minimally invasive surgical treatment of part of the coronary disease, namely the LAD, and PCI to the other significant lesions, is an attractive option for either high-risk patients or a subset of patients with anatomically suitable disease, as it avoids sternotomy and the use of cardiopulmonary bypass. It also inherently means that the patient receives an incomplete revascularization, at least for a limited time, unless the two procedures are combined in one session, which is infrequently the case. Lichtenberg and colleagues examined a cohort of 411 patients who underwent minimally invasive direct coronary artery bypass grafting of the LAD. Of these patients, 64% had isolated disease of the LAD, while the rest had multivessel disease. The latter group received incomplete revascularization for multiple reasons. The mean follow-up time was almost 30 months. After adjustment for baseline characteristic by Cox regression analysis, the 3-year risk of cardiac death was significantly higher in the multivessel disease group, with a relative risk of 2.2. The authors concluded that multivessel disease was an independent risk factor for adverse outcomes in patients undergoing minimally invasive revascularization of the LAD using the internal thoracic artery, but with acceptable midterm morbidity and mortality. The impact of incomplete revascularization in PCI has been investigated for more than 3 decades. Within this time frame, as with CABG, interventional techniques have significantly and rapidly improved, including the implantation of bare metal and subsequently drug-eluting stents over balloon angioplasty alone. A recent meta-analysis of complete revascularization in PCI included 38 trials with more than 150,000 patients. The studies were mostly observational and included large registries or post-hoc analysis of randomized trials. Complete revascularization was achieved in less than half of the patients. Odds of death, with an odds ratio of 0.69, repeat revascularization, myocardial infarction, and major adverse cardiac events were significantly lower in the patients who underwent complete revascularization. These outcomes were unchanged on subgroup analysis, regardless of the definition of complete revascularization. In the figure, risk of death in incomplete versus complete revascularization. To conclude, careful review of data from the last 3 to 4 decades, with the inherent changes in surgical technique, postoperative care, and more aggressive risk factor management after surgery, reveals a rather consistent trend toward survival benefit of complete revascularization over incomplete revascularization for patients with multivessel disease undergoing CABG. This is especially true for patients who are older and have worse anginal symptoms or reduced ejection fraction. These data on complete revascularization should consciously impact decision-making at 2 stages. The first, as part of the heart team discussion, the likelihood of achieving complete revascularization with the different modalities should be considered, since lower complete revascularization rates are consistently achieved with PCI, and incomplete revascularization is related to worse outcomes. Once it has been decided that the patient will undergo surgical revascularization, all efforts must be made to achieve complete revascularization. The option of reasonable incomplete revascularization should be reserved for very unusual cases in which a careful assessment of the risks and benefits of alternative approaches, such as including culprit lesion PCI, complete revascularization by PCI, incomplete revascularization by preferably minimally invasive CABG, and complete revascularization by CABG with arterial conduits, taking into consideration the comorbidities and personal wishes of the individual patient, leads to a multidisciplinary team decision for less than complete revascularization. Thank you for your attention.